Hello.
Jagdish, you'll have to mute a lot of background noise.
Yes, sir. Yes, ma'am. Just said hello and I leave.
Yeah, thank you for joining. Very sweet of you.
Hello.
Jagdish has a concurrent meeting going on.
Sir.
Jagdish also happened to be my student. Both of you are now very distinguished alumni in your own right. Neel also was my student at Bombay Hospital.
Sir,
Thank you, ma'am. So I will leave now. I'll join a little later.
Thanks,
Thank you.
Jagdish. Bye.
Bye.
So very good evening, and madam, we can start now our session.
Yeah.
Very good evening, and one more important session from the AACCI, and this session is basically very unique because this is the first session of our international forum for the year 2024. And before I start my introduction of the AACCI, I requesting our chairperson Dr. Yashwant Bhave sir to begin the with welcome note, and we can start that session. Sir, unmute.
Good evening, everybody, and good morning, Neel. I'm very happy to welcome all of you for this first inaugural session. It's indeed very gratifying to me, Swati, and all of us, all the volunteers, that AACCI over time has spread its wings to international horizons. That is, in my view, a great achievement. But more than that, we are very lucky to have with us panelists for this forum, international forum, and particularly today also, that add gravitas and content to the subject that is dear to all of us. I'm seeing old faces. I'm seeing Neel in particular. We welcome Neel here. He was with us some time back for the last ITPA conference in Pune, and we had a joy. I'm sure now also we'll have Donald. I was just welcoming Neel, and I said that I'm seeing many faces, own faces, and you are the most distinguished of them. So welcome to this inaugural sort of session of the International Forum. We are really touched. Thank you very much. Now, to the Executive Director.
Yeah, thank you so much, Mr. Bhave. AACCI started an international forum way back in 2022. And my teacher and my mentor in adolescent health, Dr. Grade Anas, kindly agreed to be the chair, and Dr. Anagai Jaikar from Hobart, Australia, agreed to be the coordinator. And immediately after the sad demise of my father, the founder chair, Dr. Lele, we held a session in fact, condolence meeting, and saying that we could not give a better tribute to my father than starting an international forum. Somewhere down the line, we got busy with things. So we are now revamped and rejuvenated International Forum. And I have the chair, Dr. Grade Anagai Jaikar is in Hobart, Australia. So the time zone is not convenient for her to join. But she'll certainly listen to the recorded version. And we are very happy to start the opening batsman, Neelkamal Soares, who's an expert in developmental pediatrics as well as general pediatrics. And I would like to start the ball rolling. And now every second Saturday, 8 p.m., we'll be doing these monthly programs. And our national coordinator, Samir Shah, will be informing everybody with his usual efficiency, with the banners, etc. Our chairman of the International Forum, Don, would you like to say a few words before we start?
Well, good evening to, or actually, good evening to you, and good morning to those of us in Michigan. Nice to see you all again. This is much easier to say hi to you than spending many hours in the airplane and losing lots of sleep and beating your brain up as your central nervous system ages, it's getting more and more difficult to travel around the world. But this is much easier. So it's nice to see you all again, and this is certainly a very important topic: attention deficit hyperactivity disorder, which is very controversial in the United States, and I'm sure it's very controversial where you are, and literally around the world. So we have a real expert who deals with this all the time, and I look forward to hearing what Dr. Soares has to say about this.
Thank you, Don. We would like to apologize to both Don and Neil, Mr. Bhave, and myself. We have to go to our founders' day of my hospital, which is a dinner which we cannot miss. So we just waited back to say welcome to both of you. And then I hand over the proceedings to Dr. Samisha, a very able national coordinator.
Don't miss dinner.
Yeah.
Thank you, ma'am. And once again, let's start our today's session. Before that, it's my duty as being a national coordinator of the AACCI to introduce AACCI and introduce our today's speaker also. Neil sir, can you stop your screen share so I can share my? So AACCI is an association of the adolescent and child care in India and was registered in 2007 in the Mumbai under the chairmanship of our Padma Bhushan awardee, late Dr. R.D. Lele sir, and with Executive Director Dr. Swati Bhave madam. Our mission is holistic health of the children, adolescent and young adult through their two pillars of their life, that is parents and teacher. We have added one more pillar, that is grandparents, since 2020. We do mainly urban-based work with the parents, teacher and student in school and colleges, along with all the other stakeholders who are doing for the betterment of our students. We have recently started our tribal project also, and we are very well working on it now. We have no membership fee and anyone can join the AACCI as volunteer. We have 5 regional and 5 city centers and an international forum. AACCI has done collaboration with the many organizations both at the national and international level. AACCI work has received award in many community work and any other youth-based research that what we are doing since 2007, and now we have boosted up this in 2023. We have no membership fee and anyone can join by just filling that volunteer form. You can get the more details about the AACCI on our main website, that is AACCI.in, and our AACCI training program.com. At presently, we have running 11 centers with 4 forums and more than 250 volunteers. Our 4 forums will be handled by the very efficient pediatricians across the country of the India. And now, with the help of our international volunteers like respected Donald sir and the Sarin and Anga madam, we have now started our international forum also very actively. So this is in short about our AACCI. Today, now it's a time to introduce our eminent speaker, Dr. Neelkamal Soares. Neelkamal Soares is a professor of the Biomedical Informatics at the Western Michigan University, Homer Stryker, and MD School of the Medicine in Kalamazoo, Michigan, USA. He is also an adjunct professor of the pediatrics at University of the Michigan Medical School in Ann Arbor, Michigan. He is board certified in development of the behavioral pediatrics. He earned his MBBS in the University of the Mumbai Lokmanya Tilak Municipal Medical College and completed his residency at the University of the Illusion at Chicago in medical pediatrics, followed by the fellowship in the development and behavioral pediatrics at the University of the Maryland, Baltimore. He has been involved in the clinical care, diagnosis and treatment of the children and developmental and behavioral conditions for more than 20 years and has practiced in academics and community setting at large. He has been primarily investigator and co-investigator on numerous funded studies for the federal, private, and international sources. He has over 16 years experience in telehealth. He has published over 70 peer-reviewed papers and presented scholarly content nationally and internationally. So this is the just short introduction of the Neelkamal Soares, and today's his topic of presentation is ADHD in adolescents, update for the clinicians. So now, sir, the stage is of yours. And I request all the participants, you are having any query or the question, please write on the chat box. So we can take all the questions in the end after the completion of the presentation by Dr. Neelkamal. Okay, sir.
Thank you so much, Dr. Samir, and thank you to Madam Bhave and Yash for having me here. Wonderful to see Dawn again, who I've worked with for several years. So I'll get right into it. So I have no disclosures other than I serve on the medical advisory board for Linus Biotechnology, but that is not related to this presentation. And as much as possible, I'll talk about generic medications and not use brand names in the presentation. The main thing I want to cover is really talk about how the diagnostic criteria have changed for adolescents in particular in the last 10 years as compared to before that. As it relates to ADHD, what are some of the comorbidities that you'll see with ADHD, and what are some of the treatment options, including some of the newer developments? And really importantly to talk about, since this is a lifespan disorder, what are some of the outcomes as they go into adulthood? So in the US, there are more than 6 million children, around 10% of children and adolescents are diagnosed with ADHD. It's about 3:1 for boys is to girls, more in the Black and majority white populations as compared to some of the minority populations. And almost 2/3 of them have at least one other condition, whether it be a disruptive disorder or an anxiety disorder. So usually ADHD does not come by itself. 2/3 of them are getting some treatment, mostly medication, though some, less than half, are getting behavior therapy. And in schools, they do get a lot of supports, but they're not always comprehensive supports in schools. The prevalence worldwide is not that much different. Studies in 2012 looked mainly at adults and adolescents, but if you include children, it's about 7 to 8%, and it's slightly lower in adults. It's a little hard to do adult studies, as I'll come to in a second. Adolescents tend to be more inattentive than hyperactive impulsive. So that sort of phase changes from when they're children. They get less impulsive and hyperactive over time. Adults has been a little trickier because the tools are not as robust in terms of diagnostic, and it's hard to get history from adults about when they were children. Some studies have said that the prevalence is anywhere from 1 to 6%. And a study in India had them less than 1%, though I think that is an underestimate. Most other larger meta-analyses say it's about 2%, but it depends on what method you're using. So if you just using scales, it's about 2%. It gets much less if you're using clinical diagnoses, and even less because if adults, even if they're diagnosed, they don't see as much as children and adolescents. The criteria have, which I'll come to, and that could be a reason for an increased number of diagnoses. Some studies say that there's been about a 27% increase in the diagnosis of adolescents and adults, particularly because of the change in the criteria. So by criteria, what I mean is in 2013, there was a change in the diagnostic manual. So in the US, we use what's called the Diagnostic and Statistical Manual for mental disorders, DSM 5th edition. Before that, it was the 4th edition from 1994. So before 2013, ADHD used to be considered just a childhood disorder, mainly presented in children and adolescents. But we know that you don't just grow it by the time you're 18 or 21. It's now considered a neurodevelopmental disorder throughout the lifespan, much like autism, much like intellectual disability. In the past, they used to say you need 6 criteria But now for adolescents and adults, so 17 years and older, you only need 5 criteria, not 6 in each category. And the criteria more recently, they're giving more examples rather than just saying inattention or not following directions. Now they give examples, so it's easier for both a parent and a teacher to understand, but also for the doctor to understand what exactly they're rating. This was a very important criteria change. Before 2013, they used to say you have to have symptoms before 7 years of age. Now they have increased that to 12 years of age since DSM-5. And the reason for that, they said, is it's really hard for an adolescent and their family to remember, what they were like at the age of 4 and 5, but they found that the recall was better if they extended the time to 12. Most of the other criteria stayed the same, other than a little more details. So, for example, instead of just saying must have trouble at school and at work, now they say must have trouble at school, at work, with friends, outside the home. So they give more variety for coding the symptoms. And instead of calling it types, it's no longer called ADHD inattentive type or hyperactive impulsive type. It is called a presentation, because there's really not much difference in how you treat. So there was no point in having separate types, because people used to think one type is worse than the other or better than the other. They just say, how does it present? And then they added what's called a severity scale, which would be, is it mild, moderate, or severe? So that's how things changed. And because of the newer ways of looking at ADHD in the last decade, there's been more robust attention to treatment and identification. So the most important things in the diagnosis is getting a good history, because a good history helps you rule out other things. There are a lot of symptoms in ADHD that can be imitated by medical disorders, epilepsy, thyroid disorders, sleep apnea, etc., and also other psychiatric disorders like anxiety or people who are substance abusing. So really taking a good medical history is important. Family history is important because ADHD does run in families to a great extent. Psychosocial, because if they have a chaotic family life, you want to take that into account, both in terms of how the family is functioning with this ADHD individual, but also when you prescribe treatments, how much support does the family need to get these treatments? Educational history helps you understand how the child's doing academically and what supports they might need. And developmental history helps understand, are there any areas of delays that need to either be addressed or taken into account when making the diagnosis. Usually, and I'll come to this in a second, it's important to get some standardized instruments from multiple settings. So, most of these people are in school. As they get older, they may be in the workplace, but it's really hard asking somebody's boss to fill out a form for ADHD. So I think that's another reason why people are little reluctant when they're adults or in the workplace. Also, for adolescents, as they get older, there are more and more teachers involved. If each subject has its own teacher, they may go from class to class, so it can get a little challenging. Hearing and vision can be really important to rule out. For example, if you say somebody's not listening and therefore they have ADHD, well, you can't say that if you don't know if they have a hearing loss or not. So it's important to know whether or not attention is because of a loss of or a reduction in hearing or vision. And during the process, identifying other conditions, because those conditions might require their own treatments. So, for adults also, it becomes challenging, as I said, who do you ask history from? If you have, so that's why it's a little challenging, not possible to do adult diagnoses. There are many scales out there. There are some which are called global scales, which would be not just looking for ADHD, but also those other conditions I mentioned, oppositional defiant anxiety, depression, things like that. And then there are ADHD specific checklists. Some of them go down as young as 3 years of age. Many of them usually start at around 5 to 6 years of age. There are some which are specifically for adults as well. Some are freely available. You can print them off the internet. You can download PDF files. Some you have to pay for because they're copyright. Some of them can be scored by hand. Some of them require you to have a special algorithm or a type of a carbon copy to be able to score it. So there's no real difference between the tools. Nobody has done a study which says one checklist is better than another. So people usually choose the ones that either they have a contract with or they have a lot of stock of, but the ones which are free are very popular with a lot of people. So from these, the Vanderbilt rating scales and the SNAP 4 are free, whereas the others you have to pay for. In addition to checklists, there are computerized tests in which a child or an adolescent sits at a computer and different images or different letters will flash on the screen. And the instruction is, if you see an X, press the button. And what it does is it's measuring their response rate, whether they miss something, their reaction time. And so they first let them train on it and then they get it. In other cases, if a child struggles with maybe recognizing letters or something, they can put headphones on, and when they hear the sound, you've got to press a button. So there's a version that goes down to 4 years of age and up, and another one which starts at 8 years and up. So depending on the child's age, and then you get a nice graph that comes out that shows different areas, and you can see if it's high or low. The computer test, there are many different versions. I've just shown one here. They are not considered the main diagnostic thing because, you know, the child comes into the doctor's office, does the computer test, doesn't tell you how they're doing in school, doesn't tell you how they're doing at home. If the room is quiet and there are no distractions, they can do very well on this test. I mean, they don't have ADHD. So it's really important to use this only as maybe an additional tool, or if there's some question about where you don't believe the checklists, or if somebody wants to put together a more comprehensive package rather than just looking at forms. So some people use this. I have used it in the past. I don't use it regularly. Comorbidities. So the most common one is oppositional defiant disorder and conduct disorder, where they have, you know, negative behaviors. They refuse to listen. They throw things. They fight with people. They beat people up. They steal, etc. So that's more than half of all ADHD have this. Either most likely the ODD, and a smaller number have the conduct disorder. Anxiety is very common. About 1 in 3 of them have anxiety, and about 1 in 4 of them have depression. Learning disorders, whether it's dyslexia or dyscalculia or dysgraphia, all very common. And tic disorders, whether it be simple motor tics or simple verbal tics, or a combination like Tourette disorder, they can be common as well. People with ADHD tend to have more obesity for a variety of reasons. Some people believe it's because you might think they're very hyper, therefore they should be skinny, but also they're very impulsive in their eating. So they will eat a lot and not think about controlling their portion size. They will make poor choices about the calorie contents. They can have sleep disorders, which can be everything from not falling asleep and insomnia. And in some cases, they can also have snoring and sleep apnea. Migraine, celiac, and asthma is also associated with ADHD. So I always say, if you have somebody who suspects ADHD, always do other things, because if you don't look, you might miss something. The other thing to remember with adolescents particularly is that in general, adolescents have a developing, evolving brain, and they tend to take a lot of risks. Adolescents tend to try drugs, alcohol, unprotected sex. They are very in their decision making. They can engage in reckless driving. So you have that, and the reason that's their adolescence is because they want a big rush of dopamine. They do things because they get that big rush of dopamine. So rather than going for the riskless or less risky, they go for the bigger ones. And this is mainly related to the delayed maturation of the prefrontal cortex. So what happens, usually the emotional regions, which is the amygdala, the hippocampal areas, which do reward processing, they're the ones which develop first before you have the lateral parietal and frontals, which are responsible for calming things down, taking a logical perspective. So generally, is from a treatment standpoint in adolescents, using mindfulness, using acceptance-based therapy, these are your risks, these are your rewards, what would you like to do, can be helpful. I like this next slide a lot because it shows, the color shows you age increases through. The blue is showing the mature areas. So as you can see, the posterior areas mature first, and the frontal and frontal cortex really mature later. And that's a great example how, as you're going through this, people with ADHD have these even more. So this is a normal development sort of infographic. In ADHD, it can be even more delayed because have greater difficulties with some of frontal functioning. ADHD end when they become adult, it persists, and studies have shown that it persists almost half of them. In the used to be literature said that 1/3 of children and adolescents with ADHD continue to struggle, but now it's more because people are paying more attention to the criteria, diagnosing people over the age of 18 with ADHD. So what happens is if you've got comorbid conditions like defiant conduct younger, those can persist antisocial and criminality when you're older. Not all of them, but at least 10% of them who have conduct disorder develop antisocial personality disorder. Also, if you have ADHD, a higher risk for bipolar disorder in adulthood, and also risk for suicide attempts, also higher risk for anxiety, depression, and alcohol and substance abuse. It's no joke, having ADHD as a youngster increases your an adult, and having ADHD as an adult increases your risk for a lot of other things that have more severe consequences also. So this is why it's really important not only identified but treat. So treating, at least in adolescents, it's critical to have family involvement and also family education, because there are a lot of myths about what ADHD is, what ADHD is management. ADHD is not generally a function of poor parenting or diet or things like that. Yes, there are confounding but also confounding factors. So like increased screen can worsen ADHD, but there's no evidence to suggest that just having time makes ADHD. You have to have to be predisposed and have some of the symptoms, and then things like screen or a structure that does not have nurturing supportive things, or perhaps intakes of things like that can worsen things, but they're not the cause of ADHD. ADHD is a genetically determined with environmental factors condition. Generally speaking, in the US, recommendation for what's called combined treatment, the research shows that medication works about 75% of the time, works about 65% time, but together they work about 90 to 95% of the time. So that's why I always recommend behavior therapy and medication. And in the US, usually when you're younger, under the age of 6, you always start with behavior therapy. And if the child does, then you put medication. When you're older, you can do them both at the same time, or in some cases, you can start with medication just so that the adolescent is more receptive and more focused on therapy sessions. There are a lot of very good psychosocial or behavior treatments in adolescents, including something called OST, organizational skills training. There's some parent training, but because in adolescence, just like with anything else, they don't have as much motivation when a parent tells them something. They've been pushing for peer interventions, peer-directed behavior training. And this is pretty similar. Even in the United Kingdom, they really focus, again, for young children, medication is not the first choice. And then for school age, not so much parent training, but more medication with behavior training second. Neuropsychological assessment, which is like a very robust, lots of testing, can be very expensive if you're paying cash. They'll test your IQ, your academics, your emotional. All of that is not necessary just for ADHD, but it might be necessary if somebody has a learning disability plus ADHD plus an emotional disorder. So if you're suspecting multiple things, then yes, it can be helpful, but it might be too much if a child just has, or an adolescent just has ADHD. And the rating scales are not only good for the diagnostic tools, but they can be used to measure treatment over time. So when you have somebody on a treatment package, you can collect these checklists every 3 to 6 months, see if it's improving and make changes in treatment. The psychosocial treatment in adolescents, there are several, and I have at the end of this presentation have the references for you all. I'm happy to share them. But generally, there is either with or without family involvement, working on organization, autonomy, and then cognitive behavior therapy is a very popular one. That is the mainstay treatment for things like anxiety disorder and depressive disorder, but it's found to be helpful in ADHD as well. And the main things that treatments do is they work on time management skills for the adolescent, which is one of the bigger problems. Remember, I said earlier that they're not very hyperactive, they're impulsive, they're not keeping on tapping things or jumping out of seat, not generally. But they really have trouble. They lose things. They forget to turn in their homework. They miss assignments. They don't know where they kept their keys, things like that. And when they become adults, they struggle with their deadlines. They may not learn in important papers. They might get lost going somewhere because their mind was preoccupied and they were thinking. So organizational time management skills, monitoring, adolescents rewards tend to be either, you can gain privileges, or sometimes people use money because motivated as young children for using sticker charts or like point systems. And it's really important to have what's called individual treatment setting. Find out what the adolescent wants. Are they interested? I've had several patients who come into the clinic and they just don't do anything. They say, my parent brought me here. I'm not interested in taking medicine. I'm not interested in going for therapy. So you've got to get to where they're at and say, okay, so what do you think is the problem? Motivational interviewing will try assess whether the adolescent is ready for treatment. If they're not ready, it becomes really hard to force them. But you can't just say, okay, you're not ready to buy. You want to say, what do you think is the matter? Do you know what ADHD is? Do you think you have ADHD? Okay. How is it affecting you? And in the course of the process, they need to realize that life is not much fun with ADHD. They're struggling with their relationships, they're struggling with their productivity. And then you've got to say, well, would you like things better? Do you think there's something that could make it better? So using that work of not, I'm telling you what to do and you better do it. Because it's really hard to force an adult to do stuff. They're not going to do medicine if they agree it's necessary. They're going to participate in therapy. I don't think it's necessary. Help them set their goals. Help them realize whatever they learn in therapy used outside of the therapy session. As they just go for a session, practice in the session, they leave, and then they don't do it again till the next one. Teach them how to work on their academic skills, to rethink, okay, I have a problem. My problem is, what can I do different? I'm not a bad person, just have a problem. How can I work on it? And then make sure your parent and adolescent community, because that is so important. Parents have to, or grandparents have to be involved in treatment and support adolescent without telling them what all the time. Medications with the high efficacy in ADHD, whether it's adolescent, is stimulants, either methylphenidate or some of the amphetamine salts. Population-based studies, amphetamine is probably a better choice in adolescents, but down to an individual adolescent, it could be either one. I don't know what the general research says, but I go, I have personal preference. So and some families go bad things about methamphetamine. I don't want it. I go, okay, what you heard? Okay, that's reasonable, that's not reasonable. And then I negotiate with them which one. So non-stimulants like guanfacine, clonidine, and that are used. Look at studies, they're not as effective as stimulants are. And they can have more side effects. People think stimulants have side effects. Stimulants also have side effects, drowsiness, dizziness, stomach, etc. Adolescents will refuse either because they're wrong with me or they're not motivated. And you've got to be careful with because the one you don't want is for them to pretend like they're taking it, hide it, and then either trade it or use it for some other reason, right? And this is important for adolescents who existing substance abuse. That doesn't mean but you have to be extra in terms of what are they doing, how many pills, etc. The stimulants, there are versions, there are short-acting versions, there are long-acting versions. Most of the long-actings are in adults. Short-actings not so much because adult only needs to focus for 4 hours in a day. They have longer work days, college days, and that doesn't need to be every 4 to 6 hours. The way they work is generally to increase prefrontal. Remember, I showed that graphic, that area quite developed, has less dopamine, and so the stimulants, most though they all nephrine, amphetamines. And then the same thing with the non-stimulants, they also work to increase the prefrontal dopamine. The main side effects are going to be related to appetite suppression and sleep difficulties, etc. These stimulants are also prescribed for things like obstructive sleep apnea, narcolepsy. Some people use it for traumatic brain injury to keep focus. People have used it in stroke, but they're not considered first-line uses for that. The other medicines, long-acting versions of the alpha agonists are there. Antidepressants have been pretty good in terms of ADHD in the past. The only problem with using antidepressants is they have much more side effects. They have, for example, the tricyclic antidepressants have cardiac side effects. They have anticholinergic side effects, so constipation, dry mouth, blurring of vision, urinary retention. You've got to be very careful. You have to sometimes get EKGs if they start having palpitations or feeling dizzy. And certainly they have a very low threshold for overdose. So, if you take 5 or 6 pills of a stimulant, you'll get sick, but you will not die. But if you take tricyclics, you could have a fatal cardiac arrhythmia. There is a newer non-stimulant called viloxazine. I'm not sure if it's available in India yet, but I'm having a lot of success with it because it is a little faster to effect than the other alpha agonists. Usually atomoxetine and some of other medicines, they don't work right away. They can take 4 to 5 days, sometimes even up to a week to be effective, whereas stimulants work within a day, at the most 2 days. So, parents are very eager to move quickly, but there's such a thing as having patience and going slowly because the side effects increase if you go too rapidly for any medicine. A really important thing is to avoid them, especially with the controlled substances, the stimulants, avoid them selling or using this in unapproved ways. So in the US, many times we make adolescents sign an agreement. I promise to come regularly. I promise that you will check my pills, that I will not sell it, I will not trade it with other people. If I do so, I can be discharged from the practice and be reported for misuse. So some people even use urine tests. I don't, but some psychiatrists will make the urine drug test to make sure that some of the adolescents and adults are taking the medicine. There are ways to check if they're filling the medicines from multiple doctors. That has become issue, particularly since COVID in the United States. People were connecting to doctors over the internet who were prescribing these controlled substances. And for a while, it was okay because of social distancing and the pandemic, but then they found people were contacting multiple different doctors in multiple different states, and there was no way to know who was prescribing what. So now there are monitoring programs to be sure if this person is filling prescriptions from multiple doctors, and even the doctors can get into trouble for that. If you prescribe a medicine, particularly a controlled substance, having the patient see you. They were just sending a message that person was prescribing. So that is not considered legal. Some people believe that stimulants can help you do well in exams, even if you don't have ADHD. So there's this perception that if I focus better, I'll do better. But really, the research is not supportive of that. There's inconsistent effect of stimulants on working memory and cognitive control, but the person taking it feels it's making a dramatic improvement. So some adolescents, particularly for exams, might want this. This is where that back-end trading is happening. Those who have ADHD selling their pills, they can charge as much as $3 to $10 per pill. So the adolescent is making money off this, but there are ways to sort of check this, especially if you find that the adolescent is asking for medicines before their time is up. Just got a 30-day supply, and then 10 days later, they want another 30-day supply. Wonder what's going on. But really, there's no evidence that taking a medicine is going to make a huge improvement. Now, people can feel focused, but does it really improve their functioning? That's not clear from the research. It's really important to help these adolescents in school, make sure their needs are met. In the United States, we have special classifications for getting extra help. ADHD falls in that. So diabetes, sickle cell, severe asthma, ADHD are considered chronic medical conditions, and so they get extra time, extra help. They can go take their medicine in the nurse's office if they have to. The one thing that's not in the US is teachers and the people cannot tell a parent, your child is out of control, better go get a medicine for him for his ADHD, because if you don't get it, we won't let him come back to school. They do it, but that's not legal. You can't say that. You can say your child's having trouble, we suggest you go to the doctor. You can't threaten them saying they're not allowed in school, or we will suspend him if he's not on medicine. Really important for parents is to get them ready for their next phase of life. So when they finish high school, do they want to go to college? Do they want to job? Do they want to get an extra training? You want to prepare that looks like when they become adults. Who's going to fill their prescriptions? What is their insurance? How are they going to keep on it? Because their parents are not going to be able to continue to help prescriptions all through their life. A lot of interest having medications. Obviously, a lot of families are very against it. So they ask me, and they look at say, what if we did lots of exercise? And exercise some help, but don't say it has a huge help you focus better. And what sort of flooding of your prefrontal cortex are you getting with more physical activity, but also limitations in terms of practicality, how much exercise you do. Exercise is very good for everybody, but I can't prescribe it for somebody with ADHD and say, if you do more exercise, you'll do better on your exam. There's no such thing. Supplements, so people are very interested in, can I take a fatty acid, fish oil, zinc, etc. So there's a lot of confusion out there, because some people may actually have a nutritional deficiency, right? If somebody is anemia and they feel better, because it's treating the ADHD, or is it treating their anemia and they feel and also probiotics. So it's not harmful. So if people say, I want to give them or omega fat, that's not harmful. Too many, because if you take too fatty acid capsules, you can have diarrhea, or you can feel nauseous. I said avoid what omega is. So there are people who supplement with huge amounts of magnesium and huge amounts of other things, and that's a problem. Magnesium being a divalent cation, can compete with calcium, and you can get things like cardiac contractility. Be careful not to have excess magnesium. Computer gaming, there's actually a case that's approved by the Food and Drug Administration in the US, where they give them a little game that they can download or a thing, and they 25 minutes a day, a week, or 5 days a week. And then they do that for a month. Then they take a 1 week break, and then they do it for a month. And claim the research is really unclear. The other thing is it costs money. It's not covered. So paying up to $100 every month for this. The adults have their own version, which is a subscription version, $25 a month. And it's pretty much a game. Different levels are there, and it helps them focus. There's really not good studies, but they're approved, and some families are willing to pay to avoid the hassle of medication. So I have a lot of reference. Keep time for questions also. I'm sure there are a lot of questions. I'll try my best to answer some of them. Are there questions in the chat I should address first? Or
At
let me
present, we
see.
don't have any questions in the chat. I will request the guests, if anybody has any question, you can kindly put in the chat. Till then, sir, was one question. In many schools, they give some accommodations, academic educational accommodations. So what kind of accommodations are given in US for these children?
Yeah, so there's a provision in the law called a 504 plan that was based out of a law from 1975 that's been updated. And what those accommodations are, they're divided into different categories. One is called environmental accommodations. So sit in the front row and not have to be sitting in the back. Take your tests in a quiet room so you're not taking it with all the children. Then there is activity accommodations. You're allowed to get up and move around the class if you're restless. You're allowed to excuse yourself and go and walk a little bit, or you can stand at your desk if you don't feel, you feel too restless sitting down. There's testing accommodations. You get extra time to complete a time-based test that can vary from 1.5 times. So if it's a 2-hour test, you get 3 hours, etc. Or you can have a different methodology of tests. So for example, you can take the tests and break it into sections with breaks in between. For material accommodations, you can have things like you lose your things a lot. Okay, we'll make sure that it's online for you because your papers are all over the place. Or we let you turn it in afterwards. So there are many different ways to do things with accommodations. The problem though is it's really hard to get teachers to follow through. They're very busy, lots of students. So sometimes they forget that this one student needed extra time. So it's up to the parents to make sure that the school is doing it, because the child, the adolescent, they forget. They don't know if they have extra time. They rush through some tests and they get a bad score and they feel upset. So I always say to parents, talk to the school, remind them that they are allowed to have accommodations. Usually we submit a letter saying this is what the diagnosis is. I don't actually tell them which accommodations, because nobody knows the adolescent better than the parent, the adolescent, and the teacher. So I say, please allow reasonable accommodation. Then they have to decide which ones there are. So how we usually handle the accommodations part of it here.
Some questions in the chat. Dr. Wadkar has asked few. One is, how is the youngest age we can prescribe methyl in children? Can it be given even at 4 years? And
Yes.
second question is, if there are some ADHDs later on due to some other cause like encephalitis, is there any ideal medication for it? Please, sir.
Yeah, I'll answer some of these. So the medication, the amphetamines, are approved down to 3 years of age. So I usually do not prescribe at 3, but I have prescribed at 4. The reason is, remember that thing is, if they are less than 5 years of age, the preference is therapy. So I always let families do at least 3 to 6 months of behavior therapy. And I buy some, I often say, look, 3 years of age is very young. Yes, it may look excessive, but it could be a variety of things. Make sure parent training is happening, making sure other. I have prescribed 1.5, but those are extremely out of control safety at children, and that's not one where you would want to take a chance, say, don't worry, it'll be fine. Because I have had children who have run out of traffic, almost got hit by cars. I had one young man climb on the balcony and jump off the fifth story building. So, those you just decide to use medication fast because the risk is high to just let it go. But go down to 3, I usually wait 4. Regarding, so I'll go to the next one. Will shadow teacher help? Shadow teachers can help, but it should not be a shadow that's stuck to you, because the risk is the child or adolescent can become a little prompt dependent, always turn to look for their help, wait until the help comes. You want to instill a little bit of autonomy, a little bit of competence. So touching base is shadowing all the time. So I always call it like a moving shadow. Shadow comes, shadow goes, shadow comes, shadow goes, rather than staying with the person. Encephalitis, etc. So generally speaking, there should be a difference in the treatment of ADHD because of a secondary cause, right? So let's say as long as you've treated, for example, if you've treated the condition, you have residual ADHD symptoms, I would use the same medicine I would use even if they were idiopathic, stimulants first, etc. The only ones where I'm cautious about stimulants are if they have a unstable cardiac disorder, and the cardiac, please, I do not want to use stimulants because they can slightly increase blood pressure, slightly heart rate, and so for stable cardiac, either corrected cardiac or stable, valvular defects, that's not a problem. But for example, who has hypertrophic cardiomyopathy or a stable arrhythmia stuff, I don't say I won't use it. I say, please get clearance from your cardiologist, because there are medications I can use they used to be only, methylphenidate and amphetamine. But generally speaking, no matter what the cause, I would use the first, unless there's a particular family refuses. Does medication differ in girls? No, not at all. The problem though is girls are diagnosed because they are, there's a lot of societal permissiveness. They tend to focus. Research has shown that same behaviors exhibited by boys get into trouble more than for some societal bias, the boys are being identified. That being said, boys have more ADHD than girls, just like any neurodevelopmental disorder, autism, boys, girls in terms of prevalence. And there's some thought that perhaps it is the genetic makeup and X is a little protective. Medication does not differ. Neither diagnosis criteria medications differ with girls, but to be more sensitive to identifying the girls, because they get mixed and they struggle more. Is parent training included in insurance in the US? It depends. So yes, it is, depending on what it's so it falls under behavioral health. Some people's insurance covered, some people it's covered, but pay a lot of copay. It's not covered. That's the reason, unfortunately, why people jump on medicine. Because they perceive it's faster, and because it probably than going for sessions, because the sessions they'd have to go every week for 7 to get the whole protocol done, etc. But always recommend, because the problem with medicine is it's not easy to know when to stop. Not like you start somebody at 5 years of age and you can say with any, we'll only try this till he's 8 and then he'll be off it. In at least 60% of my patients, I have now 20, 21-year-olds that I started when they were 13, 14. They're still on it. They tried to come off it badly, then they went back on it. I do try to take people off the medicine. So when they reach 8th, 9th, 10th standard, do you want to maybe try it for 2 weeks, see how your studies goes? I have only a few who do well. Most of the others, I get a message going, he failed his test. Okay, go back on the medicine. So the only trick about, when would be a time to stop. What about use of stimulants around antiepileptics? No problem at all. I've not had any issues with, because there are several patients who have epilepsy, who have ADHD. The one thing you have to remember though is because untreated seizure disorder can look like ADHD, you want to be sure you first treat the seizure disorder and see if there's any residual ADHD symptoms. I've had more than one patient who have had a medical condition, including hypothyroid, that was not responding to stimulants and non-stimulants, and then checked his thyroid level, TSH was sky high, treated that, symptoms went away. I go, see, this is why you need to rule out the medical. Transitional care for patients with ADHD. So I hope, Dr. Samir, that means like going from children to adolescents, mean by transitional care, so I know what it is.
Yeah, sir.
Yeah, so generally speaking, we really work on autonomy building. I often tell my 12, 13, 14-year-olds, look, you are going to be in charge of ADHD treatment. You need to know your medicines. You need to be able to count your pills. You need to be able to take it regularly. You need to make sure you're eating good because it can lower your appetite. You need to make sure that you're completing your work. Also make them responsible for keeping charts, keeping lists. One of my young men, he's very mad that he gets extra time. He was given accommodation. The school is happy to give. He refuses. He says, it makes me look weird. All the other kids get regular time. Why am I getting extra time? I don't want it. I said, that's okay. You don't want it, don't use it. We have it in case you needed it. And so he was okay then because he thought it was making him look weird. I said, your major exam is coming up in a month. I know you do well, but if you didn't finish when the bell rang, you're allowed to have extra time. Don't let your scores fall. And he goes, oh, I see that. He thought it was making him look like an outsider, but he got the big picture. Also with transition in the US, when they get older, they no longer on their parents' insurance. They have to get their own insurance. I have to always tell them double how much it'll cost you, where you're going to get it from. They're not going to fill prescriptions for you. These are controlled substances. You can only get 30 supply at a time. You cannot just get a year's supply. So you have to be organized. How to manage ADHD with autism? Very, very good question. The same way, but with caution, because at least 40 to 50% of the time, stimulants can have what is called a paradoxical reaction. Instead of calming somebody down, it can make them more agitated. And that's just a function of, is it making the anxiety worse? Is it making them super focused and more perseverative? I don't say no stimulants, but I say this, and I have plenty on both types of meds. I still treat the ADHD, but I caution them that side effects are more likely, therefore we have to walk more carefully. Also, you have to remember that ADHD is very common in autism. In the past, the DSM used to, before 2018, they used to forbid co-diagnosis. Now they're allowing co-diagnosis. So that's important. Don't ignore ADHD symptoms in autism. Always identify it. Does it get worse during puberty? It doesn't get worse. What happens is that there are increased risks in puberty, not only those risky behaviors, but also because they are not taking their treatments regularly, are adherent to their treatment protocols, their therapy, etc. Also, when you really start seeing the comorbid learning disorder show up or the depression, so the picture worse because other things are beginning to show up, because the treatments are not as effective because of many reasons. But it doesn't chemically become worse during puberty. Evidence to suggest that drop off in dopamine in frontal age-based. What messages or tips to help parent to manage? So it's really hard to give one set of things. I always recommend, there are many good resources online that some general principles about not, having more patience with them, repeating your actions, using more visual, verbal, like put little notes for them rather than just tell them 40 times. Also, have them be supportive, particularly when the adolescent is talking it through them. Don't get too hierarchical with them. Also, the thing with parents, some of these parents themselves have ADHD. Make sure they take care of themselves, because if an ADHD parent trying to take care of an ADHD adolescent is chaos So I always say, take care of your needs, see your own psychiatrist, make sure you're taking care of your own needs so you can be a good role model for this treatment. And then how long do we continue medication safely? It's a very good question, Dr. Samir. There was a recent 2022 publication from Scandinavia, Swedish cohort that they looked at into adulthood that said there was a slightly increased risk of cardiovascular disease over long-term use. The problem with that study was they didn't sort out which people were taking it who had pre-existing cardiovascular disease, or maybe other reasons, or maybe smoking or having habits. But the main long-term things people worry about is if they have nutrition, their weight and therefore their height can suffer. Some parents are very sensitive, have medication create shyness in my child. So that is one small risk, maybe slightly shorter if you don't eat well and if you're not monitored. There is slight increase of color, but not proven completely. However, we do, and there's ample evidence, if you have ADHD, you're not treated, your risks are massive. Your risk of having a fatal car accident, your risk of losing your job, risk of losing your family circle or your spouse, much higher. So it's all recommended. ADHD, treat it, because treated ADHD's risks are untreated ADHD. Adolescent having ADHD with depression and suicide, I would say, you want to all safety first, suicide risk precautions, but in generally speaking, stimulants or ADHD medicines work quicker. They can take away the impulsivity angle before your SSRI depressants begin to show effect. For depression, you really expect till 6 to 8 weeks of daily medication use, whereas in ADHD, you can start seeing effect 3 days, you can titrate in a week, again in another week. So I would still use stimulants for the ADHD, SSRIs, antidepressants, but I would go quickly with the ADHD because you cannot increase your suicide risk from treating the ADHD. You can increase your suicide risk from not treating the ADHD. So go quick with ADHD while you're simultaneously the other one, but know that you'll see improvement in the ADHD faster before you see. It's important to have all the support suicidal adolescent, because remember, and you know this, the first 4 to 6 weeks of taking an antidepressant is the highest risk for suicide because they go from apathy to energy, but they haven't changed their distorted cognitive thoughts. Excess screen time in a child with ADHD. So yes, there are guidance for screen time. They are not different. All kids and adolescents have the same rules. But we do know that ADHD kids are at high risk for using more screen time for multiple reasons. Number one is some parents just let the media babysit the kid because they're all over the place and that's the only thing that keeps them focused. So that's one reason why they're using more. Number two is they get more motivation, right? Their dopamine gets rising through fast pace and other things. So it's a little therapeutic for them. But it's also bad because, it increases the risk. So, but here's a set of regulations for non-ADHD. Here's a set. It's about the same. And we exclude, because a lot of, especially since COVID, a lot of education is media-based now, right? A lot of kids have online homework or they have assignments to do. Any screen time you're considering limiting should not include educational screen time. It should be entertainment only screen time. Because one of the adolescents remember saying, well, they said no more than 2 hours, but I have homework that takes 3 hours. Should I not do my homework? I said, no, you still do your homework. That's not optional. This is additional non-education related. Woo, that was nonstop. Any AI developed for the management of ADHD? There is some newer technology that involves a little bit of eye tracking and infrared, similar to the touching the computer and stuff for diagnostics. Doing that, they are looking at AI to look at different things, including a little bit of history and stuff. But the AI is being used a little more in autism than ADHD right now. ADHD is still school. The doctor gets the history, or the psychologist gets history, gets data, and that. There are online things that people do that are mostly questionnaires. And I'm pretty sure people will convert that into chatbots and anything. But the problem is the research saying there's either diagnostic or therapeutic. Remember, I talked about the games, right? So the games have been developed mainly to stimulate the dopamine and to improve the cognitive control. But those I don't believe were done with AI. That's done with traditional gaming. Because they're pretty much action games. Any specific diet avoided? Not really, though a little bit of research says that those who have food sensitivities to certain types of foods or certain types of dyes should not. But it's not like those are causative of ADHD. People believe red or yellow causes ADHD. That's not true. But if the child, after elimination diet or is seeing every time they eat a certain food, they have data to shows up, then yes, maybe avoid it. But it's not a carte blanche. Everybody gets better with a gluten-free diet or something. Not true at all.
Is decreasing sugar in the diet helpful?
Not if it's going to lead to malnutrition. I always say sugar has no more than what? So refined sugars are worse than complex carbohydrate and other sugars. But it's a myth that sugar is an etiology for ADHD. The problem is the child is hyper, they don't control their intake, they have 10 candies in their mouth, now they get hyper because of the sugar rush. So people, there it is. But it was pre-existing, worse by the very poor choice. So I always say, be mindful of your total intake, because that could, even if they had lots of thumbs, whatever, right? Anything with sugar, caffeine, etc. What professional choices are ideal for adolescents with ADHD? Anything. There are tons of amazing physicians, engineers, ADHD is not career limited. In my opinion, it's in some place career enhancing, because it's always good to have an ADHD on the team. They think outside the box. They multitask. As long as they have control enough to get back to the baseline and work with people, they're incredibly effective. You just have to balance them off with some other people on the team. But tons of people with ADHD are highly successful. It's what drives them, and they get their dopamine from certain things, and so they don't like to be buttoned down well, which is why don't do well in some careers but extremely well in others. But I don't think there's any evidence to say ADHD does better in one. It depends on their particular potential, interest, and
Thank you very much, sir. Questions in the chat box over, and we had a wonderful collection of questions, and it was very nice to hear sir on them. Tamir sir, please continue.
Thank you, sir.
So it's a non-ADHD comment. What we can say by the Neil Soren. Excellent presentation is what we expect from, and we will definitely like to go for a more and more presentation that will be analyzed in many other way also, because these are the something out of what the questions was asked in the chat box. But to the reality require a practical tips from to get the experience. That is, your experience says answer immediately without any hesitation what we can. Really, it's a to hear you, sir, and we will definitely plan one more. If possible, we can keep a next your time next. So as per national forum every second Saturday month. So let's see how we can further for with some any tips what you want to give quick, sir.
Want to thank everybody for asking amazing questions. I think you all will do such a good job with your patients and the family treat, because you're in improving their lives. As long as you follow good guidelines, use good judgment, and make sure that you support them, they will be very successful. Individuals are not sort of doomed to failure. They're very successful as long as they use treatments and those can be any types of treatment. So thank you very much for allowing me to be part of this group.
Thank you, sir. On behalf of the AACCI, no doubt you are the one part of the AACCI. Really thanks you, excellent session on the ADHD, and we can now conclude this session on behalf of the AACCI and meet on the next episode. Thanks a lot, sir. Thanks to each and every participant actively participating in the question answer session that enlighten us a lot about the practical tips that will be we can miss if we will not discuss during the question answer session. Thanks a lot, sir. Okay. And good day to Dr. Neel, right? Okay, sir. Thank you.